So when there's a case of the individual with autism and behavioral challenges, and you are called to help, what do you do at the first? What is the most important to find some solution?
Um, one of the most important things we reassure people when we arrive is that we're not the experts. So when we come to a situation, we would say, like, you're the expert. If I come to a family, you are the experts. You know your child very well. We're only here to ask you some very some important questions and to offer some solutions and to bring the knowledge that we have about behaviour to the information that you have about your child and try and put those two pieces together to make a very nice package for the child. We absolutely, our first point would not be to focus on the behaviour of the child and try to change that behaviour. What we try to do is look at everything that supports the child, all the elements that are surrounding that child. In particular, two big pieces that we would look at are the environment. Are there elements of the environment that are causing the child to have to behave in the way that they're behaving, and are there adjustments we could make to that would support the child not to have to behave that way? So for example, if the child doesn't like loud noises and the environment is loud, can we all speak in a whispered voice? If the child doesn't like particular foodstuffs, can we adjust the foodstuffs that we're providing to the child so that they don't resist those? Anything outside of the child's internal state. And the second thing is then we look at the internal state. So the physiological well-being, the biological well-being. Is the child in pain? Is part of their presentation of behaviour a way of telling us, I'm in pain and I don't know how to tell you this, so I hit myself on the face to tell you I have a toothache because I don't have the words to do that, and I expect you to understand what I mean when I do that. And I really see that as the role of a behavioural specialist, is to almost be like an interpreter. So somebody who takes the behaviour that the child does, translates that into language that is understandable by the people that care for the child, and then we try and put together a package that supports the child.
So does it mean that the family usually doesn't see what causes the behavior because they are too close?
Possibly, yeah. Sometimes.
Too emotional, maybe.
Yeah, absolutely. Sometimes, and that's in a family situation, or even in a school situation, or in a care situation, a residential care situation. That oftentimes the people that are closest to the situation can't see that. And we have an expression in Ireland to say, you cannot see the wood for the trees sometimes, that we're so close to the situation, we're so involved. And really what we're trying to do, particularly from family situations, we're trying to stay afloat. We're just trying to get through the next 5 minutes, the next 5 minutes, the next 5 minutes. And part of our job is to come in and help you to not just be dealing with the situation, but to try and get ahead of it, to try and get proactive about it rather than reactive. And it can be very frustrating for a family when we come in and say, and offer very simple solutions to what seem like very complex problems, and the family can almost be embarrassed or upset that they didn't see this and feel guilty that they should have seen it. But it's exactly that dynamic that sometimes you just cannot see it because you're so involved in it. Mm-hmm. When we come with those simple solutions, that's when you feel best about your job, because we don't want to bring really complex and complicated behavioural strategies and technology and all of that to it if we don't have to. If it's a simple answer, we like to find a simple answer.
Mm. There's a tendency in Czech institutions to see the child as a problematic, the child is the problem,
Yeah.
and not to see the problem is outside and has
Yeah.
to be solved from a different way.
Sure.
Is it typical in Ireland in the thinking of social carers too, or are you further?
We're further. I mean, I'll be perfectly honest. we are further, but we still have the challenges to change the thought processes and the ethos and the attitude towards behaviours that challenge. And so language is very important for us, and myself and my colleague Morris. We really advocate that we see behavioural difficulties as behaviours that challenge, as opposed to the phrase challenging behaviour. And that might seem like a small point, but it's an important point, because if I say that an individual has challenging behaviour, then I give responsibility to that person for everything. and I say, you are challenging and you need to stop being challenging, and this is not my fault, this is your fault. If I say that an individual has behaviours that challenge, what I'm saying is you're presenting with some behaviours, they're challenging me to try to figure out what's happening, they're challenging me to try and find a different way to support you, and they're challenging me to give you a different way to communicate your message to me. And that if we can get to that, if we can get culturally and from an attitudes point of view, people who support people with behavioural difficulties to think that way, then they start to see the situation differently. Our behaviour, the carer's behaviour starts to change, positively influences the service user or the client's behaviour, and the whole thing becomes an easier situation. So.
Yeah, yeah. What is the role of the psychiatric care in Ireland? Because in Czech Republic, sometimes happens that the child with the behavioral challenges living in an environment that can't solve it somehow gets into the crisis and then is hospitalized in a psychiatric ward, sometimes for months or even years. Is it possible, such a thing in Ireland?
Not really, not really. It would be very unlikely, highly unlikely that a child would be placed in a psychiatric institute as a child. We do have adults who go into crisis, and it's easier for them to access services if they don't have an intellectual disability. If the person does have an intellectual disability, then the mental health services in Ireland, the psychiatric services would very much resist accepting responsibility for that person. And that can cause a lot of difficulties. It also happens in children's services because in Ireland we have what are called the Child and Adolescent Mental Health Services, CAMS for short. And in Galway we have children with autism, with behavioural difficulties, with intellectual disabilities, and with mental health difficulties. And we would often have disagreements with CAMS because they would say, well, you're a disability service, so it's your responsibility to look after them. And we would say, but this is a mental health issue. And a child, just because they have an intellectual disability, it does not mean they can't have a mental health issue as well, like depression, anxiety, anorexia, true mental health problems. And we're not looking for you to admit the child in a crisis. We're looking for you to come and bring mental health expertise to support our disability expertise and our behavioural expertise to create a package for the child. But they're very resistant to supporting that side of things. We've had loads of experience. I've had loads of experience of people with intellectual disabilities and behavioural issues who really do experience mental health crises. And we have to fight very hard for them to get into the crisis placement in the mental health services, but that will only be for a short term. But the treatment that they get in the mental health services can vary, and can sometimes be detrimental to their well-being. And then because of funding issues or resource issues, they might find themselves staying there for a very long time because there are no resources provided to support the level of difficulty that they have when they come out of the mental health services. And the person gets caught in the middle. Psychiatric service doesn't want to keep them, and the disability service doesn't want to receive them until they have the money and resources to do so. And it can be it can be very damaging to an individual.
Generally, you don't think in Ireland that the medication is the solution for the behavioural challenges?
Well, there are numerous reviews, systemic reviews, so particularly Cochrane reviews, looking at the role of psychotropic medication in behaviours that challenge, and the general acceptance is that psychotropic medication does not have any influence on behaviours that challenge whatsoever. So that would be the general acceptance. However, if somebody is in pain and they need an analgesic, they need pain medication to reduce their pain, that then is going to influence their behaviours that challenge. So if I have a toothache and I'm punching myself because I have a toothache, and you give me pain medication to reduce the pain, and I don't hit myself as much. So we might use medication that way, not psychotropic, but so we might do something like a pain trial, where if we are struggling to figure out why you're punching your face, we might, with cooperation with the medical services, general practitioner, and we might say, well, we are going to give you analgesic pain medication 3 times a day for 1 week. And we're going to watch and see how much you engage in this behaviour. and then we're not going to give it to you for a week and see does that increase, and then we will give it to you again and see does it decrease, we can make a reasonable, very strong, reasonable assumption that you're in pain and that this is something we need to focus on. So we do have people on psychotropic medication. One of the issues that Maurice and I raise is that very often the side effects of that medication cause more problems than the problem that the medication was given to the person to address in the first place. And in the case of something like Ritalin, for example, which is a medication that's given for hyperactivity, 1 in 10 people will experience the side effect of hyperactivity, which is in medication like Risperdal, which is an antipsychotic, Tegretol, which can be given as a mood stabilizer. 1 in 10 people have the side effects of those medication that will be given to you for agitation and aggression are agitation and aggression, and many other things. So,
sorry, stop, please. I need to change my memory card.
Yeah, no problem. Okay. So you came here to explain the system of home sharing.
Mm-hmm.
How would you describe the advantage of it and what it has brought to the families of people with disability in Ireland?
Yeah. So that was one of the principal reasons we came here, was to introduce the concept of home sharing and talk in more detail with people about it. And my position for talking about that is simply that myself and my wife, we are a home sharing family, but also that I deliver training to home sharing families, and I'm part of the system that I'm part of the system in the organisation that coordinates and supports the whole home sharing model. And my experience of it is that at a very basic level, it can qualitatively and quantitatively be proven that it is better. It takes away, it gives the child a natural family to be supported by. It takes away, and I tell this in a funny way, it takes away what's in a care institution is institutional care, and it removes the institutional care from that situation. So the child goes and lives with a family that is looking forward to that child coming, that has everything set up to look after that child, that has been trained, that has said, we are very committed to looking after this child. And the child goes into an environment where there is no frustration, there's no agitation, there's no lack of staffing, there are no resource issues, there are no all of the frustrations that we have in our services, and has a lovely experience in a natural family, or sorry, in a home sharing family. And the natural family get a break, very simply. They get a break, and they don't get a break putting their child into a residential care home or an institution. They get a break knowing that their child has gone to another family that has been very well trained and vetted and can be trusted to look after their vulnerable child.
Perfect. I think this is okay.
Okay.
Yeah. Thanks, Brian.
Okay. Kieran will be laughing now. Kieran see that, if he ever sees that, he'll go, that's my job. I can give you, off the hard drive, I can give you the home sharing video.
That would be perfect.
Yeah.
And you said that the Hansa has it.
Hansa has it in a
subtitles?
subtitle thing, but the program that converts the
Yeah.
subtitles wasn't on my laptop. But
Yeah,
yeah,
yeah.
you can get the other version of
Great,
Hansa
yeah.
might be better again. But
We just made a video of asking people to consider became the home sharing family.
and
Like-
see,
like-
we haven't done. See, you do stuff better here. we didn't do that because recruitment is so in part of the process is recruitment, and so we put up posters and we send out flyers and we tweet and we put it on Facebook and we and put it in the newspapers and things like that. But actually, I'm going to go back and say that we haven't done a media piece where you have a nice.
I'll show you a piece.
Yeah, please,
It's a
because-
couple of minutes.
But one of the very
Okay, Maurice. So tell me, when you are called to case of some severe behavior that challenges, what do you look at first? What is the most important in the evaluation of what to do?
Okay, on first arrival at a situation where a person might be engaging in behaviours of challenge, I will look to see that the individuals in that area are both okay, both the person that we support and the staff, because usually when I'm called, the situations are pretty serious. So I need to make sure that both people in that equation are okay. When I've established that both the person we support and staff are fine, then I start to look at possible causes. Okay, I will have a number of individuals on my caseload. So currently it stands at about 70.
70 people.
70 people.
70 open cases.
70 open cases. But what I do is I operate a system of red, amber, green. So sometimes people are in that area where their behaviour is well managed. So I might see individuals like that maybe once, twice a year to make sure that things are kept. Amber would be people who maybe are on their way down from maybe fairly frequent events of behaviours to challenge, or somebody on their way up from green for some possible cause. So for me, I have a certain knowledge of the individuals that I'm coming to support, and for those individuals we already have written guidelines in place. So I go back and I see, have we strayed from the written guidelines and agreements that we had? So we will have consistent approaches across all staff groups in relation to the behaviour of those 70 individuals. The top 20 or 30 will have very comprehensive guidelines written by me, and they'll also have psychological interventions, they'll also have pharmacological interventions, and there may be OT or physiotherapy support. So when I arrive, I look to see first what went wrong. Okay, and
So
that
use the history.
yeah.
Yeah.
Okay, and I suppose that's a nice position for me to be in, but if you were to take it in terms of the school, if you had somebody supporting the students here and the pupils here, after a period of time they get to know them quite well, and so do the staff. And if you have agreed and consistent guidelines in place, and you have a consistent approach from psychology and all the other professionals, then when something goes wrong, we look for a possible cause in there. If I find that the cause is somebody has deviated from an agreed strategy, then we usually go back to the staff and say, what happened and why did it happen? And so we question people involved to say, okay, this incident happened, how? And I begin to get a history of the event. And in that history, I will know whether they stayed on track or they didn't. And if they didn't, I'll ask, well, why didn't you follow what was agreed? Because we know that the agreed strategies actually help this person have a good quality of life. If you don't, the person escalates, goes into crisis as we discussed. And then I get the phone call to come and see, can we fix it? And I'll say, well, the individual that we're supporting didn't break it. You broke it. We need to get back and make sure that we follow what were our consistently agreed approaches.
So it looks like that you follow very transparent logic how to solve the problem. Does it happen to you sometimes that the behavior is mysterious for you, that you can't find the cause?
Yes.
Only some case.
So in the case of an individual lady that I mentioned inside, we couldn't find the cause, and it involved self-injury. So, and I know her for some time. With self-injury, our first port of call is pain. So I don't go anywhere else until I've examined whether pain is part of the possible cause. In that, I will talk to, we have a very close relationship with our doctors. So I'll speak to the GP, general practitioner, and I'll ask them if we can do a pain trial with an individual. And a pain trial might involve introducing pain relief medication 3 times a day for a 5-day period. And we will have tracked the behaviours before, during, and after.
So this means that you don't know the cause yet, but you are just watching what the analgesics will do with the condition.
Yeah, we will. So I will ask GP to examine the individual first, see if there's any obvious cause. If there isn't, we may presume pain, particularly in self-injury, in this case. And then I'll ask the individual to help me with that pain trial. I can't start a pain trial on my own. It has to be on the advice of a general practitioner or on a nurse prescriber. So a nurse prescriber will have completed a very high level course in prescribing medication. Okay. If we find during the pain trial that the behaviour decreases, then the possibility of a pain will be high, so we may go for further investigations. In the event that we do that, then we have got to involve our local hospital, where I will go with staff and we'll meet relevant professionals to see if they can advise us in any way. Now, there are waiting lists, so sometimes we get put on that waiting list and we have to manage the behaviour to the best of our ability until we find a possible cause for it. If we find the possible cause, with this lady, the pain medication actually had a big effect. So we realised it was pain, and for her it was sinusitis, okay, caused by her putting pieces of tiny fabric up her nose, and infection was setting in and spreading out into the sinuses, okay. So she was in deep discomfort, right? So we had an individual who knew somebody in ear, nose and throat, and they got an appointment and they were seen and this stuff was cleared out, and antibiotic therapy as well, and the behaviour reduced by about 90%. We still had 10% of the behaviour. So we now have to manage that 10% of the behaviour, and sometimes that might mean that we might go in and help that individual physically stop actually hurting themselves. And that involves special techniques we use in redirecting movement of the hands. It doesn't involve restraint, it just involves redirecting a hit away from the face and just completing what we would call circular movements to give a person a break away from them.
You are learning to be here and not here.
Yes, yeah. Well, what you would do is I might actually, if you could let me hold your hand. So if you were going to hit your face, I would just redirect the movement away like this. So.
And that's how you learn me to do it?
Well, what I would do is I'm trying to actually protect you at this moment in time.
It's a protection.
It's a protection mechanism. It's not a learning piece. It's a protection mechanism.
Yeah.
Okay. So I don't want to sit and watch you hurting yourself. I know that we've tried to address the pain. There may be some other possible causes that we can't get to yet. So at those moments in time when you are most at risk to yourself, we will try and help you by redirecting your hands away from your face. But we're not into, I don't want to redirect you down here because I'm not solving the issue. I want to actually stop you hitting yourself. Then we try to discover, okay, what other things may be in this person's life. So in the case of this individual, they were on the autism spectrum. And she's in an environment where other people do things that she doesn't like. One of them was leaving particular doors open. And I don't know, does the word laundry or a storeroom for clothes and towels and all that? Yeah. Somebody kept leaving that door open and it frustrates her greatly. And she wants it closed. And somebody opens it and she wants it closed. So what we agreed with the staff was on her behalf that the laundry door is always locked. Okay? Then we would go to our Human Rights Committee and say, this door is locked, but it's on her behalf. Okay? She requests that this door is closed. It's not a restriction on her. She can gain access to the laundry if she asks, but she doesn't want to. But she wants to be sure that that door is closed. And now the behaviour begins to fall away some more. Okay? If she needs then a place to relax, we have a garden area she can go to, or she can go to her own bedroom. She particularly likes a walk, but she particularly likes a walk after travelling a short distance on a bus. Okay? So we believe the bus helps her with that vestibular movement, and it actually helps her with walking. So if she has relaxed with this kind of a movement, she's far more amenable, she's far more agreeable to a walk. And we begin to see, well, okay, when we introduce these things, the behaviour still falls away.
And you are all the time talking about the one lady. Okay, so this is very complex set of causes with the main and the pain, but several more.
Yeah. Now, I suppose to understand for this particular individual, she hurt herself so much here that part of her ear began to necrose, it began to die from lack of blood supply. So on her behalf, we need to protect her as much as we can because that's very, very serious. So this is quite comprehensive, and she would be in the red group of people for me. So I have to spend longer within that group of individuals than I would with any other. So I have to commit time to that person. Okay. Now, I will say that in her case, she has wonderful staff. She has extremely good staff who will follow the lead of someone like myself because they trust me. So if I come and I say, these are the strategies that we need to put in place, they'll do them. Otherwise, I'm just writing words on paper. It won't make sense. So if people are prepared to follow the strategies, then you generally see a reduction in the behaviour because we've agreed these strategies, we've investigated the pain, we've looked at the environment, we've done as much as we could there, we've spoken to the management team to try and keep a consistent staff level. And then we've said, okay, this is the agreed protocol that we're going to follow, and we will follow that every time this happens. What happens is people follow the protocol, things start to get good, and then everybody thinks it's solved. And then they stop following the protocol because they think they don't need it anymore. And then people go from green back into amber and back into red quite quickly. So from myself and Brian, we would say these strategies and these plans that we have in place are there for a reason. They keep a person on that quality of life path. If they veer off the quality of life path, then they're into the behaviour side of things, and we need to get them back on. And that's the way we kind of focus. That's the way I focus my attention. And so far, we've been pretty successful in reducing behaviours, but I have never been successful in eliminating a behaviour completely.
Completely, yeah. So what is can you say some average, or does it have an average?
I said our averages are high because I work on the principle that if you have good management strategies, the behaviours fall away. Okay, if I try to change your behaviour, that's a complex set of skills that I need to put in place. You might say, in order to change your behaviour, that could take years, and it probably would. If I manage your behaviours in a certain way to help you kind of go in a different direction, that's far more successful for us, and it yields immediate effect. So when you look at that positive behavioural support piece, you see behaviour management before behaviour change. A good behaviour management strategy might mean you never have to get into that behavioural change model, okay? Because the behaviours will change quite naturally. If you do need to get into that behavioural change model, then that's a very, very complex piece of work carried out by an individual who knows what they're doing through the functional assessment and then applied behaviour analysis techniques. If I can get there much quicker than that, then I will take those management strategies, put them in place, and you find that the better the management strategies, the better the quality of life. Okay, so if you take that lady, her face is clear. When you see her now, you wouldn't know that she self-injures because her ears are good, her face is, and she's smiling for the first time. Now, I can tell you that that's successful. You have to trust me. But there are others who still hurt themselves. And they hurt themselves quite severely. But they used to hurt themselves 10 times more. So we've managed to reduce that down as well. But it didn't stop the hit and the hurt for some of the individuals. It just reduced it. And with one particular individual, we had to agree that there was a certain number of hits that he would do at a very low level that were acceptable, because if you stopped them, what followed next was catastrophic. Okay. He would pick the hardest object in his environment and hit himself as hard as he could off it. So the low level, low frequency, low intensity, we used to say, well, okay, let's accept that that's something that's fulfilling something for him. Because if we intervene, what happens next is far more detrimental to him than this low-level piece. So sometimes you have to agree those as well. They're difficult because what you're saying is there is an element to this self-injury that we're saying is okay at the moment, because not to allow it causes the catastrophic event. And then we say, okay, well, let's work on this for a while, see where we go, and then let's see if we can reduce this. Thankfully, that lowered as well. Okay? So we've been successful most of the time. 70-80% of the time we will have reduction, maybe more, reduction in behaviours. But I will say, hand on heart, elimination for me, I haven't seen it, because the nature and the cause are sometimes different, or sometimes maybe invisible. We can't see it. We've tried pain. We've tried everything in our repertoire to eliminate this behaviour, and there's still some elements of it left.
The system is sometimes so specific that in a normal
Yeah.
environment, simply happens.
Yeah, exactly.
Some kind of stress.
Yeah. Yeah, and if you take the general population we work with, there are a lot of events in their life that are anxiety causing. New staff, new environment, different environment, not at home, no mommy and daddy, kind of all those things that we would take for granted in our life sometimes are absent from the lives of people that I might support. They mightn't see their family only once a month and they might miss them hugely. So I can't, what I'm saying is I can't eliminate the causes. Therefore, the behaviour will surface from time to time.
Perfect. I think this is enough.
Okay.
Thank you.
You happy enough?
Yep.
All right.
Thank you.